welcome all of you to the webinar on our preeclampsia, improving healthcare response to preeclampsia, our toolkit. And Dr. Shields is currently the Director of Maternal Fetal Medicine at Marion Regional Medical Center in Santa Maria, California. He is also the co-chair of the Dignity Health Patient Safety Improvement Coalition, and is also been the chair, one of the chairs of our preeclampsia toolkit, and is currently the chair of our preeclampsia collaborative. So hopefully he can get his webinar back up on speed and we can get started.
Let me know when you think you're back in, Larry.
Okay, it's got me listed, and then...
Okay, I'm going to change the role to presenter. Can you see anything now?
Now okay, I think we're good. Sorry, everybody. I think we're good to go. Is that correct?
Can you see your slides, Larry, on the WebEx page? Because now I can't see them.
I can. All right, thank you.
You can?
Assume we're ready to go. That the slides didn't change.
If anyone has any questions or technical issues, you can type something in the chat to me and I will reply to you separately.
The little arrow's not working.
Can you see the slides, Nancy?
Yes, I can. Larry, do you see at the very top you have under your LS 223 tab? If you click on that, you'll see the slides.
Right, but they don't move.
Do you see the little arrows?
Yeah.
Right below that on the tool.
Nancy, thank you.
Okie dokie.
So, I don't know why it's not working.
Well, if you like.
Okay, a few people are saying that they can't see the slides, and I can't see them, so I don't think anybody else is going to be able to see them. Let me change myself back to the presenter. Okay. Now let me try you one more time, Larry. I've got two Larrys on here, so I don't know which Larry is you. Okay, Larry, can you see now? Can you move the slides?
No. I see the slides, but I can't move them. Do you want to just pull them back to the
I can just forward them. Just let me know.
Yep, let's try that.
Val.
Oh.
Okay, I'm going to make Nancy the presenter, and then she can forward them for you, Larry.
Okay.
All right, here we go.
There, great. Okay, so thank you, and hopefully this will eventually work here. I just wanted to, have this slide to let everybody know all the people that really spent, many, many, many hours putting this toolkit together that, you guys are able to download at this point from, really kind of all parts of our state, San Francisco, San Diego, and from a variety of different organizations and backgrounds. So that's, people should be grateful for all the time that these people spent putting this together for us. Next. So, the learning objectives were really to kind of, have a little bit of review of hypertensive disorders in pregnancy and delineate, some of the causes of morbidity and review some of the data from CMQCC of why we moved in this direction, and then go over some key elements of the toolkit. So Nancy, if you want to move on. So this is a slide I stole from the co-chair, Maury Drusen, who wanted to make it pretty straightforward and simple when he was presenting the toolkit last. He says, it's not really rocket science, it's not brain surgery. We only have 4 classifications of preeclampsia, and management can be divided really into 5 different elements. I wish it was that simple. I would agree it's not rocket science, but it's certainly not as easy as we think, or we'd be doing a better job. Next. So, you know, one of the problems is it's really not just four separate things. We do have gestational hypertension, preeclampsia, severe preeclampsia, eclampsia, all kind of funnel, you know, in a line there. But then off to the side, we have chronic hypertension, superimposed preeclampsia. We have posterior reversible encephalopathy syndrome in patients that frequently have eclampsia. Then we have our atypical presentations, or patients that come in and they may have normal blood pressure, but they have a seizure anyway, or they come in and they have normal blood pressure and they have HELP syndrome, or patients that present with just proteinuria and then subsequently come back and have preeclampsia or severe preeclampsia. So it's not as straightforward as we all would like it to be, which makes things somewhat difficult. Next. The other part that's, I think, playing into why we're seeing more morbidity from preeclampsia is that the incidence in the United States has increased by 25% in the last 2 decades. And, you know, no surprise, I think, to the people on this phone call that it is responsible for a significant number of maternal-related deaths around the world, 50 to 60,000 estimated. Next. So if we look at the California perinatal mortality review information from the first 2 years of reviews, which were outcomes from 2002 to 2004, which was 145 pregnancy-related deaths in California, it became really clear that the focus had to be on both preeclampsia and OB hemorrhages. Most people know the OB hemorrhage toolkit rolled out, I believe, 2011. Correct me if I'm wrong, Nancy. And the reason that was chosen first is because almost 70% of those cases were thought to have a strong or good chance to change the outcome. And then when you came to preeclampsia, it was not much different than sepsis or DVT, but the prevalence is so much higher that the impact is greater. And so the next area that CMQCC and the state decided to tackle was preeclampsia, and that's the toolkit that we see at this point. Next. If we look at the reasons that most of these patients are dying, it's from hemorrhagic stroke. 87% of the patients that have a stroke, it's hemorrhagic, and of the patients that died, 64% of them had a stroke. There's obviously other causes: cardiac failure, hepatic failure, multi-organ system dysfunction, and hemorrhage, which is seen more frequently in our patients with preeclampsia. And we'd like to, next slide, Nancy. You know, I'd like to think that we've, you know, learned and are able to improve our outcomes in our patients from preeclampsia. But if you look at this cohort of CDC data that was collected over a 14-year period, published in 2001, but ended in 1992, you know, the rate of death from preeclampsia is almost exactly the same as we saw in California in our more recent cohort, and the cause of death, again, about 90% from hemorrhagic stroke. And so we've made very little impact here on the likelihood of reducing maternal mortality from preeclampsia from the most common cause. Next. And unfortunately, you know, mortality is an easy endpoint to measure, but it's certainly not one that we want to see, and not one that we want to use for the measurement. So if we look at pregnancy or preeclampsia-related mortality in California, it's a relatively small cohort, and, you know, people have used this iceberg rendition of how this rolls out with near misses, which is, you know, critical patients that require ICU admission, approximately 40 to 50-fold increase in the number of patients we see that actually die, and then serious morbidity that is most easily defined as required increased length of stay in the hospital during the course of their labor and delivery process, being a 400 to 500-fold increase. And so that's the area where we're seeing most patients are going to see the issues. And the impact of hypertension, I think, can't be just related. You don't just see it in our deaths for preeclampsia or eclampsia. If you look at the cohort of patients who died, only 17% were thought to have preeclampsia pre-eclampsia, but of the patients that had a pregnancy-related death, nearly 40% of them had hypertension complicating their course of pregnancy. So the presence of hypertension in pregnancy is not only an increased risk for preeclampsia, eclampsia, but it's also a marker that suggests patients increased risk for morbidity and mortality in their course of pregnancy. And that's not too surprising, but also the fact that we're seeing a significant increase in the number of our patients that have preeclampsia throughout the state and nationally. Next. So, this sort of goes through the process that CMQCC used for identifying cases and how we put together the two toolkits. It's a little different understanding of the slide I showed earlier, looking at kind of a quality improvements process. The cases get identified, they get reviewed by a multidisciplinary team. We figure out the cause of death, but more importantly, we figure out contributing factors in areas where there might be opportunity for improvement. Those are put together at the strategies, and then those are put together as part of the toolkit. And the toolkit is really not meant to be a textbook related to the issue of hemorrhage or preeclampsia, although there's a lot of background information there. It's really designed to have practical items within the toolkit that people can use to better take care of their patients, particularly in areas that have shown to be areas within the reviews that show that quality improvement is likely to be able to be obtained in that area. Next. So
Larry, excuse me, this is Valerie. Your voice was cutting in a little bit and out a little bit, so it was a little softer, so just make sure you speak right into your phone set.
Okay, I'll try to do that. Sorry. As everybody knows, at the end of last year, ACOG published their executive summary on hypertension, which was a 2-year project initiated by ACOG president at the time, James Martin, who has spent his entire career looking at preeclampsia. Next. So the executive summary came up with ideas that should be considered parts of best practice and have identified forms of severe preeclampsia that continue to challenge physicians, and those are part of that sort of Venn diagram that I showed you in the beginning, and recommended that there needed to be improved patient education and counseling, as well as strategies to more effectively identify our patients and treat them for preeclampsia. Next. The definitions that the ACOG used in their hypertensive group didn't really change from the basic definitions from 1972, 90, or 2000, and there still remained the 4 basic categories that we had in that very first slide: gestational hypertension, preeclampsia, severe preeclampsia, eclampsia, with superimposed preeclampsia on chronic hypertension. Next. And so this is just a slide outlining those, chronic hypertension obviously predating pregnancy or present in the early part of pregnancy when you don't have values earlier in pregnancy, and gestational hypertension occurring after 20 weeks. And these are essentially the same. However, they did make some significant changes in what we were going to refer to as preeclampsia. Preeclampsia is no longer supposed to be referred to as mild, and severe is supposed to be with or without severe features. And the idea here was that by labeling something as mild preeclampsia, it was immediately putting less emphasis on it and the likelihood of there being any sort of adverse outcomes for that patient being minimal. And so the idea is that we would eliminate that term from the nomenclature. The other big change was that proteinuria was no longer a requirement for the diagnosis of new onset hypertension to be called preeclampsia, and a total proteinuria of greater than 5 grams in 24 hours was no longer a diagnostic criteria for severe preeclampsia. And I'll go through some of the the criteria that have remained. And that one of their final recommendations that early treatment of severe hypertension is mandatory at a threshold of 160/110, which has always been, present as part of the diagnostic criteria, but there wasn't as strong of a recommendation for treatment at that threshold. So if you look at the diagnostic criteria, they're the same. Preeclampsia that is without severe features is going to have blood pressures of 140/10 over 90. As you get to the more elevated levels, 160 over 110 is going to fall in the severe category. Proteinuria, if present, will confirm the diagnosis of preeclampsia, but doesn't eliminate it as a possibility, and that the presence of any of the other findings, thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, or the CNS abdominal symptoms would also be part of the diagnosis with severe features. Next. The other thing that remained is that the diagnosis was made after a period of verifying the presence of features consistent with preeclampsia or severe preeclampsia for 4 hours, but it was not, what was not left in place is that or was changed, or the recommended change was that you didn't need to wait 4 hours before you started treating the patient, and that the blood pressure, if you have severe range blood pressure of diastolic of 160 or, systolic of 160 or a diastolic of 110, that this should be repeated within 15 minutes, and if persistent, then that patient should receive antihypertensive therapy within 30 to 60 minutes, or as soon as possible, is outlined in the new ACOG summary. Go ahead.
It's stuck now. Not letting me advance.
Not just me.
Nope. It transferred to me.
Well, we are definitely having technical issues today. It won't let me be the presenter.
Huh.
Okay,
try it again. Okay, it's working now. Go ahead, Larry.
Okay, thank you. I apologize, everybody. I'm not particularly technologically savvy, I would say, even though I have a bunch of computers laying around. But so I'll take blame for why this isn't working, but I don't know why. So the other, so what we came up with in the toolkit is a variety of what we refer to as key clinical pearls, so that just to kind of, hone in on features that everybody that was members of the task force felt that these are common things that people forget, or they get admitted, or they're just ignored. And so, the number one was patients with vague symptoms such as headache, abdominal pain, shortness of breath, generalized sweating, or more importantly, I just don't feel right. Those patients need to really be evaluated for preeclampsia or severe preeclampsia, and appropriate evaluation of them should take place whenever they present, regardless of whether their blood pressure is elevated or not. Next. And then the task force recommended that patients that have elevated blood pressures be monitored in the hospital or an outpatient equivalent for at least the first 72 hours, so that they could either have a health visit or they come back to your office if they're discharged prior to that point, and that they should again be seen in the postpartum period between 7 and 10 days in patients that delivered with symptoms or had a diagnosis of preeclampsia during the course of their hospitalization. One of the other, and these are sort of interspersed in here at various points, and so sometimes they make total sense and sometimes they don't, so I threw this one in here because I couldn't find a great place to put it. But, one of the other key clinical pearls is that, someone who presents with new onset hypertension or new onset proteinuria has about a 40% chance of developing preeclampsia. So if you have someone who's developed 1 to 2 plus proteinuria and it's 28 weeks, those patients really deserve a higher level of surveillance, just like they would if their blood pressure elevated to 140 over 90. And frequently that gets overlooked, and they're scheduled for routine follow-up. The other thing that came out of the task force review was that the patients that develop significant complications from preeclampsia tend to present earlier in their pregnancy than patients that had deaths that were unrelated to preeclampsia. So if you look at the group that were less than 37 weeks. 56% of the pregnancy-related deaths fell into that category, and that's not surprising if you're at a center that sees a lot of patients with severe preeclampsia, but we tend to think of preeclampsia as a disease of young primipterous women at term, when the reality is the significant complications fall into the age group that's actually below that, and frequently they're not prima gravidas, and frequently they're not young. They have other comorbidities such as diabetes, obesity, or...
You're cutting in and out again, Larry.
Well, I'm doing the best I can.
Okay, we'll just keep going then.
I'm 13 inches from my phone. So the next key clinical pearl was that the patients with preeclampsia, particularly severe, can have rapid progression and develop significant morbidity and mortality related to that, and that we need to keep that in mind, particularly in patients that are being admitted for conservative management of severe preeclampsia prior to 34 weeks gestation, that this is a high-risk group of patients. Next. And so there are recommendations within both the ACOG executive summary, and then there's some elements within the toolkit for monitoring the patients who present greater than 24 weeks but less than 34 weeks with severe preeclampsia, and that it is okay to monitor those patients in a hospital setting as long as the maternal fetal condition remains stable, and they initially would be admitted for corticosteroids, magnesium sulfate, and then monitored for other severe complications. Next. And so there's some guidelines for initial management, as I was just mentioning. Daily labs rule out HELLP syndrome, renal insufficiency. They should be monitored for development of pulmonary edema. And if you're in the absence of these things, it's okay to continue these patients to 34 weeks gestation, at which point all experts tend to agree that delivery is balanced by the risk of prematurity versus significant maternal morbidity. Next. And if you look at this, there's a sort of chart table within the toolkit that just kind of goes through there for daily checks to be going through the mother. And if any of them, the answer is not no, then you need to move towards delivery. And it's pretty straightforward. They are mostly all of the severe features of preeclampsia. Next slide. In the absence of elevated blood pressure that you've been able to stabilize, or proteinuria. IUGR is no longer a requirement for severe preeclampsia, and you can have IUGR according to ACOG and the CMQCC toolkit, long as fetal testing is reassuring. But you must have the absence of severe features as noted here: CNS symptoms, GI symptoms, pulmonary edema, oliguria, HELLP syndrome, evidence of worsening renal function. Next. Laboratory assessment is relatively straightforward, like you would do in all of your hypertensive patients. And we did add the caveat that, some patients will present with abdominal pain that is not related to preeclampsia, and we need to think about those patients with other abdominal causes for their pain, gallbladder disease, or pancreatitis. But I think what we don't want to do is go down that route first before we've eliminated the possibility of the much more common likelihood, which is they have preeclampsia. The group of patients to develop with severe preeclampsia, they have elevated blood pressure, they have HELLP syndrome, and then develop a seizure, are one of the highest risk for pregnancy complications and much worse outcomes, as you would expect, from placental abruption, renal failure, subcapsular hepatic hematoma or hepatic rupture, hemorrhagic strokes, preterm delivery, and fetal maternal death. And so just to remind people that, if your center is not really able to handle those sorts of patients, they should really be transferred out after being stabilized to a center that has the capacity to take care of all of these complications. The recommended timing for delivery really, I don't think, changed, but got emphasized a little bit more clearly. For gestational hypertension or preeclampsia without severe features, delivery is recommended based on the Habitat study that was published in 2009 in Lancet at 37 weeks, or any time after 37 weeks when this develops. And then moving on to sort of a different topic is some of the quality improvement measures that we identified within the pregnancy mortality review group is, you know, if you look at both developing and developed countries, the issues surrounding patients that develop preeclampsia and their outcomes are almost identical. You know, there's usually lack or poor prenatal care, there's delay in diagnosis and treatment, there's sort of unchecked progression to severe preeclampsia, so a patient that might have developed proteinuria or might have developed hypertension, and they're given a routine follow-up instead of more frequent follow-up. Lack of access to hospital care, so patients without transportation issues or have difficulty getting in and out to hospital or transport to a tertiary facility because of their geographical location. Many times, even our staff in the labor and delivery units don't see complications for severe preeclampsia that frequently, particularly in our lower delivery volume settings. And so there can be issues related to education of our staff and available resources such as medications and readily available laboratory or ICU capabilities. And so these were identified within that cohort and surprisingly are almost exactly the same wherever you go in the country. And so part of the process that we want to effect is to eliminate as much of this as we can through different elements. The other element that was pretty, I think, interesting when you looked at the group of patients that died from preeclampsia versus the total cohort, granted the numbers are relatively small, but the number that had delay in diagnosis in the preeclampsia group was felt to be over 90%, and the use of ineffective treatment was significantly higher in the preeclampsia group than in the cohort in general. And a classic example of this is, you know, the patient has blood pressure of greater than 160 over 110, and they're given magnesium sulfate under the impression that they're going to improve their blood pressure with magnesium sulfate, which doesn't really do that, and so that would be considered the use of an ineffective treatment. And then regardless of you know, the gestational age or where the patient has been seen, any patient with severe preeclampsia should be seen by an obstetrician. You know, our ER colleagues, as good as they are, or you know, other outpatient settings, really are not that familiar with this disorder. And so one of the key recommendations was that any patient suspected of having preeclampsia, severe preeclampsia, should be seen by an obstetrician as soon as possible. And what became clear from the mortality review cohort and from ACOG's review, and if you go to the United Kingdom and look at what have they done as part of their quality improvement measurements that they have rolled out as part of their reviews of maternal mortalities in the UK, that what they found is that controlling blood pressure was the most optimal intervention that improved death within the UK from stroke from preeclampsia, and they've shown a remarkable reduction in this complication in their country relative to prior to instituting fairly strict guidelines for blood pressure treatments, similar to the ones that we've put in the toolkit here, as well as the ones that ACOG put in their new recommendations. The other thing that became evident is that there needs to be some sort of tool for identification of clinical signs or clinical triggers that can aid in the recognition and response and avoid delay in treatment of preeclampsia. As we all know, some of these patients will evolve over, you know, very short periods of time on our labor and delivery unit. And so within the toolkit, we developed a modification, next slide please, of what's been published in the British system, but tried to make it more directly related to preeclampsia. So the preeclampsia early recognition tool, and this is something that's going to be coming out, I think, for use in all OB patients within the next year or two from a variety of sources. But basically, if you're in the green area, there's nothing really to worry about. As you move into the yellow area, there's more significant concerns, and obviously patients that are in the severe category need to have an entirely different response than someone that's in the green. Next slide. And so there's some recommendations here of what to do. In the green, you proceed with your current management plan. Yellow, if there's one of the triggers there, the physician needs to be notified and be made aware that status is changing, and if there's two or more, then there needs to be an in-person evaluation and an escalation in the acuity of the patient and the level of care that he's receiving, and obviously with number 3, there needs to be other more significant interventions and considerations for care of that patient. And this is a slide that Dr. Drusian put in, a very famous quote, it ain't over. And this is just to remind people that, patients do develop postpartum preeclampsia, and we need to think about this until they've reached their 6-week postpartum visit. The other reminder of this most recently got put out there was the concept that the risk of thromboembolism continues not just to the 6th but to the 12th week postpartum that was in the news within the last week or two. Next slide. So if we look at the different groups of patients here, the non-preeclamptic and the preeclamptic patients, you can see particularly in that 3rd and 4th week, but all the way out to the 6th week, you see that we saw problems in that population of patients. The numbers tend to be in that 2 to 3 to 4 week time frame, and so we need to remember that as our patient goes home and they call back complaining of different changes or headaches or other complaints that they didn't have previously, that it's probably worth bringing them in and taking a look at them. Next. Eclampsia is, I think, relatively well known to everybody. Hopefully most people don't have an opportunity to see this very often. It should have an incidence of about 1 in 1,000 deliveries in the United States. In the United States, if you do have an eclamptic seizure, it's about a 1% risk of death, significantly lower than other developed countries, but certainly something that increases the probability of an adverse pregnancy outcome. Next. And if you look at this group of 250 consecutive cases, the Sabbai published back in 1990, the numbers were, I think, surprising to most people when this study first came out, that 1 in 5, or 19%, didn't have proteinuria but came in and had a seizure that was consistent with eclampsia, and that 1 in 4 didn't have hypertension that people would consider in the severe range. And so the idea that you can have an eclamptic seizure in someone that doesn't have severe range blood pressure obviously is there, or proteinuria. Next. In the same group of patients, it was interesting that about a third occurred postpartum, and of the postpartum cases, 55% were more than 48 hours after delivery. And so, again, this is part of that recommendation that patients get seen or have some sort of follow-up for that first 72 hours and then seen more frequently afterwards. And again, blood pressure was not a significant complaint or finding in these in over half, but visual changes or headache complaints were present in every one of them. So again, keep those subjective symptoms in mind as patients call in with questions or concerns. So some of the specific recommendations from the toolkit I've put together here. Obviously, you can't cover everything, but I think you can bring it down into some salient components. One is blood pressure control, one is seizure prophylaxis, one is delivery at the dates that we've already talked about, and then postpartum surveillance or treatment, as I've mentioned a number of times. Part of our problem with blood pressure control is in the past and I think this is probably the main reason why we haven't seen an increase in, a decrease in the incidence of stroke related to preeclampsia, is that up until 2012, the recommendations for ACOG is that you would treat with either hydralazine or labetalol for blood pressure that had a systolic of greater than 105 to 110, and there was really no mention of what to do with the systolic blood pressure. Next slide. But if you look at a study published by James Martin, who's the same one that ACOG is to revise these recommendations, you'll see that 96% of these women had a blood pressure greater than 160, and 100% had a blood pressure greater than 155 systolic. But if you look at the diastolic blood pressure of 110, only 12.5% had that, and these are patients that had stroke during the course of their pregnancy, typically around the time of delivery. And so the focus here was that we really need to concentrate more on systolic blood pressure if we're going to reduce significant morbidity, particularly CNS morbidity related to preeclampsia. Next. So one of the clinical pearls that we wanted to put out there is that, the initial and probably most important step in reducing morbidity from preeclampsia is that hypertensive medication should be administered within 60 minutes of a critical blood pressure, which has been defined as 160 over 110. And ideally, the medication should be readily available, and there's a little diagram and chart list of things that you might include in your preeclampsia box that is kept on labor and delivery, so you don't have to go to the pharmacy to get your labetalol or your hydralazine or your magnesium, that it's really available to facilitate treatment on labor and delivery. The other recommendation is due to that paper from Martin and people's bias from review of our own mortality cases in California, that we suggested that there should be alternate triggers, and that people should feel that if they have a patient with a blood pressure greater than 155 over 105, they should feel perfectly comfortable treating blood pressure at that time before waiting to get to the higher level, which is thought to be the absolute requirement for intervention. The other component was that, it doesn't really matter what form of high blood pressure you have, whether it be gestational hypertension, preeclampsia, or severe preeclampsia, that they all warrant intervention. And so if you have someone with severe preeclampsia on blood pressure criteria alone, that should be someone who still gets intervention. The recommendations for high blood pressure treatment, first-line medications within the toolkit as well as within ACOG are IV labetalol or hydralazine. But frequently, you'll want to initiate treatment in a patient who may yet to have IV access, and oral nifedipine should be readily available for use for this. And then, although some people had recommended oral labetalol, due to the much longer time to peak action, that this is not going to be something that's going to be very effective in decreasing acute blood pressure elevations in patients without IV access. Clearly, you could use it for maintenance once the blood pressure has been lowered, but we wouldn't recommend it as one of the primary first-line therapies. Next slide. And this is just a chart that I pulled from the toolkit showing the onset of action and the peak duration to action from the different medications. And as you can see, PO nifedipine is going to have an onset somewhere between 20 minutes and 2 hours, with a peak not occurring for 1 to 4 hours, which is significantly different than you would see with IV labetalol or hydralazine. Next. And this is not to really go over all the details of how to give IV labetalol, but just to show that there are algorithms in place that you would hopefully have posted in your labor and delivery unit. Next slide. For either labetalol or hydralazine, so that people that aren't used to using it have readily available access of when to give it, the dose, and how frequently the follow-up doses should be under what circumstances. Next. And I mentioned this earlier that, it's very frequent that people will expect magnesium sulfate to produce a antihypertensive effect. But if you look at data that was published by Michael Belfort, he took a group of mild preeclamptic patients, so we don't have severe patients in here. He gave them a 6-gram loading dose and then 2 grams an hour, which is a pretty hefty dose of magnesium, as I think most of you would agree, and looked at their blood pressure. And you can see, at the systolic blood pressure at baseline, 30 minutes, and at 2 hours didn't effectively change, and neither did the diastolic blood pressure. in this cohort of patients that he was evaluating. Next. And then the question, is, why do we use magnesium sulfate? I think it's pretty standard in all OB units at this point, and it all goes back to the MAGPIE trial published in Lancet in 2002, which looked at 10,000 women that were randomized if they had the presence of mild preeclampsia, defined as a blood pressure 140/90 plus proteinuria. In that study, they were able to show that there was a 58% reduction in maternal seizures. There was a nearly 50% reduction in maternal deaths and a 33% reduction in placental abruption. There's an asterisk there on the maternal deaths because of the small number of maternal deaths. Sample size, we didn't see a reduction in that wasn't statistically significant, but certainly is clinically significant. Next. So the recommendations for the use of magnesium sulfate in preeclamptic patients is shown here by a variety of different organizations: ACOG, National Institute for Healthcare Excellence, from the UK, Society of Obstetrics and Gynecology of Canada, CMQCC, and the World Health Organization. And you can see clearly for severe preeclampsia and eclampsia, every organization listed recommends the use of magnesium sulfate. For preeclampsia without severe features, it's a little bit more controversial. ACOG has suggested that it not be administered universally. The British group does not recommend it. Society of Obstetrics and Gynecology Canada and CMQCC took more of a tempered view and suggested that it should be considered in patients with preeclampsia without severe features, and clearly patients that seem to be progressing. And the World Health Organization recommended that it be given to all patients with preeclampsia. And the difference here is primarily how you identify the prevention of seizure. So if you have severe preeclampsia, you needed to treat 63 patients with magnesium sulfate to prevent one seizure, and if you have mild disease, you needed to treat 109. So it's just really a matter of the numbers and what seems to be appropriate. I always make the comment that you have to decide what's more readily treatable on your unit and what would you rather have, someone on magnesium sulfate or someone having a seizure, and is it really worth that extra 40 patients being treated to prevent that? And if only each individual unit can answer that question. So we recommended selective use in patients without severe features. Next slide. And this is sort of the key clinical pearl summarizing, that we thought that should be considered without severe features, but obviously in patients with severe features. Next. And ideally, as I mentioned, with the different algorithms for labetalol and hydralazine, that these should be either posted or readily available in all clinical areas that are going to have patients that are pregnant. So your labor and delivery, your operating rooms, your postpartum units should all have these readily available or posted in an obvious spot. Next slide. This is an example of the emergency medication box that I mentioned earlier. I'm not going to go through the details, but this is one that was put together at Stanford University and contains different elements that they wanted on hand on their labor deck for this purpose. Next. And then this is the follow-up information that is similar but not exactly the same as what ACOG had recommended, that early follow-ups to be present for all patients with preeclampsia or eclampsia. So you should receive follow-up within 3 to 7 days if you required medication during the course of your labor and delivery or postpartum care, and within 7 to 14 days if no medication was used. And then any patient presenting back to the emergency department or with hypertension, preeclampsia, or eclampsia suspected, they should be admitted back to the obstetrical service. Other key things that came out of this, and primarily related to the quality review cycle that I showed earlier, is that there needs to be a variety of team training, communication strategies, and checklists to allow continuous process improvement strategies to be taken care of for patients with hypertension. This would be things that would be included here would be on-unit debrief for anybody that had severe preeclampsia requiring acute blood pressure lowering. And the other would be that we need to have, really well-defined patient education strategies targeted to the educational level of our patients. So those are going to vary from site to site, from patient to patient. And then we need to increase the patient's awareness of signs and symptoms of preeclampsia so they don't present after they have the procedure, after having persistent headache or blurry vision at home for 3 or 4 days. And this is just an example of a preeclampsia educational pamphlet that can be obtained from the Preeclampsia Foundation or preeclampsia.org. They had members that helped us with the toolkit. They also sat on and helped with some of the guidelines that were put out from ACOG as well, and have a very educational website for patients that have preeclampsia if you want to refer them to that site. Next slide. So finally, I think this is my last slide, is that I think we've done a good job taking data that we were able to establish or that was already in the literature to create some tools and new recommendations that are very consistent with our national organizations. Ideally, each site, to get these in place, is going to have to establish champion and collaborators. Group of hospitals that participated in the Preeclampsia Collaborative have made remarkable improvements in not only their ability to treat patients with preeclampsia, but also process improvements on their labor and delivery unit that will be adapted to all their OB patients. And these will be key for getting our providers to provide changes. Having ACOG on board, I think, is a key feature there, because ACOG is essentially recommending many, if not all, of the elements that we have put together in the toolkit, just in a different format. And so we have, I think, convincing evidence that we can improve clinical care. And once we get this out there, I'm hoping that we'll see a reduction in our morbidity within the state of California, at least from the toolkit. I think that's my last slide, if I remember correctly. And then this is just where you can download the toolkit. My understanding, correct me if I'm wrong, but it's been downloaded about 1,400 times at this point from every state in the United States and 13 or 14 different countries, so it's been received quite well around the United States and elsewhere. And so I think at this point we should open up for questions or comments from anybody that's on the call.
So this is Valerie at CMQCC. I want to let you know that I've opened the line so that all conversations can be heard at this point. We do have one question that has come up, and the first question is, any comment on the use of mag sulfate in the postpartum patient?
Right.
So I don't quite understand the question. Clearly, someone who is delivered and has preeclampsia would be receiving magnesium during their postpartum period. Right. And the recommendations vary depending on whether they have previously called mild disease or severe disease or preeclamptic. Yeah.
So I want to remind everyone, we can now hear all the conversations that are happening throughout everybody's locations on the line. So if you don't want us to hear us, then you need to mute your line by pressing *6 or to not talk. So I wanted to ask Ann Burke, did that answer your question, Ann, about mag sulfate in the postpartum period?
Hi, I was specifically asking about the postpartum readmission patient.
Can you hear me?
Go ahead.
My question is, if a patient already have a hemorrhagic hemorrhage and does magnesium sulfate make it worse?
So the question is whether magnesium sulfate is associated with a higher risk of asymmetrical hemorrhage?
No, the question is, once the patient come into the unit, already have a hemorrhagic hemorrhage that will be admitted to the ICU, do we still use magnesium sulfate?
I'm sorry, I'm having a hard time hearing.
So the question is, Larry, if the patient has in the ICU with the hemorrhagic hemorrhage, would they still use magnesium sulfate?
If the patient meets criteria for the use of it, you would still use it, yes.
Okay, that's my question. Thank you. By the way, this is Doctor's Medical Center in Modesto. We tried to check in earlier, but was not able to.
Okay, great. Thank you. So there's another question about, can you comment on the SMFM finding that IOL at 37 weeks gestational age had adverse outcomes for the neonates?
Okay, so I'll be right there.
I'm not familiar with what abstract you're referring to. On the line, more specific?
It sounds like we're really having a lot of technical difficulties with the phone line because the questions are cutting in and out, and my line is echoing. I might recommend to everyone that if you do have questions, put them on the chat, and I will collect them, and we can try to put a question and answer page on our website for this call.
I mean, all I can really address from that is, you know, if within the published literature, and this primarily comes from the Habitat study, was that delivery at 37 weeks was associated with improved maternal outcome with no adverse outcome in the neonate. So, and I was at SMFM, and I don't remember that specific study, but different issue.
Okay, there was one more question. Maybe we can try to answer that. What outcome measures do you recommend hospitals track?
I think that's an interesting thing. A variety of organizations have chosen to track how well they repeat the blood pressure within a timely fashion, i.e. 15 minutes, and verify whether it's elevated or not elevated, as well as getting timely administration of antihypertensive medicines when they're necessary. Others have decided to track to make sure that patients are being discharged or having appropriate follow-up, meeting the guidelines hearing from. The other thing, those are things that every hospital can track. If your delivery volume is really large, you might be able to track individual hospital changes in morbidity, but because the significant morbidities are relatively uncommon, it's going to take a long period of time to change those. So if you were going to develop a quality improvement process for your individual hospital, I would choose things that are going to be measurable within the volume of patients that you have.
Okay, and we might try one more question. Any recommendations for postpartum readmit for preeclampsia? And before you answer that, Larry, I just want to let everyone else on the line know that the slides will be available on the CMQCC website by the end of the week. So you want to address postpartum readmit for preeclampsia recommendations, Larry?
And so I think if the patient comes back and has signs and symptoms or clinical findings of preeclampsia, they should be readmitted and they should be treated with magnesium sulfate. And I would urge every hospital to figure out how to make arrangements for those patients to come back to the OB unit, because I think they'll be more effectively treated there than on a med-surg floor that rarely ever sees a patient with preeclampsia.
Okay, I don't see any more questions. I want to let everyone know that the call was recorded. The link will be posted on the CMQCC website along with the slides that are available. There are no CEUs available for this conference webinar. Any other questions that people might have? Nancy, Larry?
Oh. No, I think, again, just please feel free to contact us if you have any questions. There's also, if a lot of people had trouble hearing because of the technological problems, we also recorded the webinar from January 30th with Maury Drusen that I think we didn't have so many problems. So please feel free to listen to that one as well. But thank you all for joining us, and again, holler if you need us. Thank you.
Thank you, Larry.
do